Hello friends, good evening. Myself Dr. Sandeep, physician from Jayanagar General Hospital. Today I am going to teach you about S2. Before hearing this presentation, there are some prerequisites. The first thing is use your headset for better audio experiences. Second thing is you please take your notebook, pen and make your own notes for better understanding and remembering the concepts. Now coming to S2. Okay, that is second heart sounds. It occurs due to closure of aortic valve and pulmonary valve. It has two components, A2 and P2. This A2, usually the P2 occurs after A2. These are coincident with the incisura of aortic and pulmonary pressure curve. It also indicates termination of left ventricular ejection time and right ventricular ejection time. The RV ejection time is more prolonged than LV ejection time. Therefore, pulmonary valve closes later. So the P2 occurs at later stage. Now the next concept is hangout interval. It is the duration between crossover of pressures between LV aorta, LV aorta, RV pulmonary artery at the level of incisura. Now, what do you mean by the term incisura? Incisura is a notch in arterial pressure curve when A2 or P2 occurs. That is when aortic or pulmonary valve closure occurs. So, you will understand these concepts better when you see the diagram. See, this is the pressure tracing of the LV. Though the LV pressure decreases, but the aortic pressure doesn't decreases suddenly. There is a time lag for decrease in aortic pressure after the LV pressure declines. And when the this is the incisura, this is the notch where the A2 occurs. At the level of the incisura, you measure the duration of the corresponding pressure of the LV. That is this from ear to ear. This is the dark shown area. So this is the hangout interval. This means even though the LV pressure drops, the aortic pressure doesn't drop suddenly. It takes some time. This time lag is known as hangout interval. That means the aortic valve closes a bit later after the LV pressure falls. Similarly, in the RV, when you trace the RV curve, this is the incisura notch, though. So this is the RV curve. Though the RV pressure declines earlier, the pulmonary artery pressure declines at a later stage. There is a time lag, and at this level you measure the duration from year to year. So this is called as Angot interval. The Angot interval of the pulmonary circulation is longer. So the Angot interval in systemic circulation, it is less than 15 milliseconds, whereas in pulmonary circulation it is 43 to 86 milliseconds. Factors affecting Angot interval are: it is inversely proportional to impedance or resistance. That means systemic resistance is more, so the Angot interval is shorter, whereas pulmonary resistance is low, the Angot interval is longer. Second, it it is directly proportional to compliance. That means Angot interval increases when there is a dilatation of aorta or pulmonary artery. Third is it depends upon the phase of respiration. So you will understand the phase of respiration when you understand the normal physiological splitting. Normally in expiration you hear a single art sound because the A2 P2 gap is less than 30 milliseconds. But inspiration, the gap between the A2 and P2 widens, so you hear a split. This is called as physiological splitting. Why it occurs means during inspiration, due to negative intrathoracic pressure, what will happen? Increased venous return. So prolonged RV ejection time, so which causes delayed P2. Understand? Now let's go to the diagram. You will understand the various types of splits. So this is a normal physiological splitting. That means you ear split only on inspiration. Next is wide physiological splitting. This means you ear split both in inspiration as well as expiration. Next is reverse splitting. This means you ear split only in expiration but no split on inspiration. The next one more entity is there, that is called as narrow physiological splitting. Here the gap between A2 and P2 is, although it is less, but P2 is very louder, so you hear the two components in spite of low gap between A2 and P2. It is seen in pulmonary hypertension. Now, next is let's move on to we shall discuss about the causes of wide physiological splitting. So, the wide split that means A2 and P2. So, the most common cause is delayed P2. It might occur to delayed electrical activation of RV such as RBBB or LV pacing, LV ectopics. Here there is a relative early LV activation. Next is prolonged RV mechanical systole seen in acute pulmonary embolism, pulmonary hypertension with RV failure. Next is pulmonary stenosis, moderate to severe. Next is decreased impedance seen in pulmonary artery dilatation. Next, also impedance is decreased in ASD as well as there is prolonged the blood flow from the shunt from LA to RA. So there is RV flow is increased and the RV ejection time is increased. So there is a prolonged RVET and prolonged RV ejection time which results in delayed P2 and the split is fixed due to lack of respiratory variation due to shunting. Okay, so it might also be due to early A2 seen in shortened left ventricular ejection time because in MR due to backward flow and in VSD due to shunting, so the LV ejection time is decreased. So now next topic is reverse splitting. This is A2, sorry, it is due to P2 and A2. It is most commonly due to delayed A2. Delayed A2 might be delayed ELV electrical activation such as LBBB left bundle branch or RV pacing or ectopics. Or next is prolonged ELV mechanical systole seen in LVOT obstruction such as HOCM and AS, ischemic heart disease and hypertensive heart disease. Next, due to decreased impedance seen in post-stenotic dilatation of aortic stenosis. Next, it might be due to early P2 seen in WPW type B and RV pacing. Hello friends, good evening. Let's move on to the part 2 presentation of the S2. Normally, S2 is better heard over bass. When you say loud S2, when S2 is louder than S1, so what are the causes of loud A2? Hypertension, aortic aneurysm, syphilitic AR. The A2 is timbre-like quality and atherosclerosis. When you say P2 is loud, P2 is equal to A2. Very loud, P2 is more than A2. Causes of loud or P2 are pulmonary hypertension, pulmonary artery dilatation. Now let's move on to the next topic. Single S2 causes. All causes which delay A2 and split less than 30 milliseconds. So this is normal A2 P2. When there is a narrow split such as A2 P2, you hear single S2. Later what happens? Before the reverse split, it becomes single S2. Then what will happen? The P2 will become early and then A2 it will become later. This is reversed split. So all causes of reverse split at one stage it causes single S2. So next cause is pulmonary hypertension, equal pressures, that is RV pressure equal to LV pressure seen in pulmonary hypertension. Second is Eisenmenger syndrome. At one stage RV pressure is equal to LV pressure. Next cause is absent or soft A2 or P2. Sorry, it is in aortic atresia A2 is absent, whereas in pulmonary atresia P2 is absent. In severe AS A2 is soft. In severe PS P2 is soft. And other causes such as truncus arteriosus there is a common trunk. Next is double outlet, single ventricle. It might be DORV or DOLV. Now next topic is what happens to S2 in Eisenmenger syndrome. In VSD, there is a single loud S2. In PDA, it is closed split S2. In ASD, it is narrow fixed split S2. And I forgotten to tell you other causes of apparent soft P2 where you will hear also single S2 or obesity, emphysema. Okay. Next is in AST when you will get variable split. One is sinus venosus type of ASD. Next is ASD with atrial fibrillation. So next is where you will get wide fixed split causes. One is ASD, ostium secundum type, PAPVC. Next is RV failure. Next is massive acute pulmonary embolism.